can you actually, you are in profile. Turn to the left. Yeah, now we see you in the and can you both introduce yourself first? Because I know you guys have done an amazing work.
He has no mic.
Don't have mic. I'm Karthik.
So,
yeah. It's Karthik from Chennai.
Chennai.
Okay, nice to meet you.
Karthik has done an amazing work. Thank you so much for what you did.
And Max from Paris, France, from
Okay.
doing this crazy work with your first and 20 years, as he said. Okay, so back to the discussion. So, liquid nobody. So, first, as you know the audience and the moderation panel, liquids are getting more and more popular. Myself, I'm using it every day for leaders, for candidates, for peripheral AVMs, and more for prostate as well. So what can we say about liquids? There are different kinds of liquids. There are VOH-based liquids, and here in India, you have squid, and you have onyx. So onyx is from the florence, squid is from plant. Glue. Unfortunately, I have no ability to show you glue today, although it's a very toxic liquid. It is already. And that you're using it a lot.
Yes, we do. Yes.
Yeah. And I don't know about the pricing, but I mean, for us in France, it's not so expensive. In the US, I know it's very expensive here. I have no idea.
Glue is not expensive. Glue is cheapest.
Glue is cheap.
So we use it extensively here.
You use a lot of glue.
Yeah.
Okay. So, EVMH-based agents are basically cohesive agents that are different viscosity, and to be radiopaque, they need to have some tantalum, reason why they need to be agitated before use. So I don't know if you can see that here. There's this vortex machine. If you can show this on the screen.
So Mark, yeah, we see that, and that's what has been started with Onyx. For a squid, do you have to use that too?
Yes. For
Okay.
squid, the difference between squid and onyx is basically the tantalum is micronized, it's not the same tantalum. So it's possible that you need less agitation. So here you have onyx 34. I know that here you only have 34 in for peripheral normalization, which is a high viscosity. What we use in France and in different countries is 18.
We do have 18 for neuro. Yes.
18 for euro, okay. But for squid, if you go back here, sorry for the camera, I need to switch again. Yeah. So squid is this one. This is 34. So like onyx, purple onyx.
Show it this way, Mark. This camera, yeah, exactly. Thank you.
Can you zoom in a little bit? Okay. And also 12. And 12 is good for prostate. So these days we are doing a lot of prostate, and basically a lot of prostate is squid 12. So maybe I can switch to the injection demo of onyx for you to have some nice video show. So maybe you can do the syringe. Can you see this on the screen?
Yes.
Okay, so as you know, you need to prep everything with EVOH. And then when you have prepped the catheter with EVOH, then you can push slowly. The onyx and squid would be basically the same. So I don't know if you can see on the video here. You can see.
We see your hand, but we don't see.
On the laptop. Okay, so you see my hand. So I'm trying to show you very, very slow injection. What you need to take into account, as you know, is that it creates pain. So you need to prep the patient with painkillers.
So what you said, EVOH, actually you prep the catheter with DMSO. Then,
I do.
yeah.
Exactly, yeah. With DMSO, that's right.
And then you inject the EVOH.
Yeah, so can you see the microcatheter?
Very well, yeah.
Okay, so I'm just pushing slowly. So now I'm pushing through the dead volume of the microcatheter.
Show the tip. Show the tip of the catheter. Yeah, don't show your hand. Show us the tip of the microcatheter.
Can you see the tip of the microcatheter?
No.
Okay. So they need to switch the video feed. They're trying to do
Yeah, now we see it. Yeah.
Okay.
No, he's focusing on that.
You can zoom a little bit on that, that would be great.
Okay, so you see it's going out with the flow, and
Yeah.
then it's rapidly getting cohesive, because it's a big flow here. So we're trying to feed an AVM or something, going down the flow. I think everybody can see on the screen.
Yeah, so
Okay, questions?
question is, can't you, usually you want to form a plug, yeah, exactly. So is it possible to inject this a little bit slower to see if you can form the plug around the tip of the catheter? Because one thing we know for EVOH is that as slow as you go is still faster than what you want to do. So really it should go very slowly, very slowly to create a plug at the origin. When you create that plug from the origin, then you start to feel the rest of it.
So I'm trying to create a plug, and I was too fast, and the flow was too fast, and the flow model
Exactly.
went down, which is not what you want. What depends on the situation. Yeah. So basically, when you have a plug, as you said, it will go further deeper and down from distal. So you can feed in the AVM or prostate like that.
Very, I think there is a friction noise with the mics. So
I'm still pushing slowly, as you can see maybe.
yeah, and that shows really well what happened in the vessel. You start to feel around the vessel, and then you see that if you inject, it's going to occupy the rest of the space. And it's very important to keep doing that, because you, when you look at the 2D angiogram, you have the impression that you already feel the vessel, but actually you just see the periphery of the vessel, not the center. So if you don't keep feeling, you have an early occlusion but very rapid recanalization. So don't think that with EVOH we can't have recanalization. Actually, the majority of cases recanalize if you don't get the plug and totally feel it.
So I think we're done with this one. The microcatheter went out, so maybe we can move to the next station and discuss a little about liquid embolic if you want at this stage.
Yeah, let's, while you are going to the next model, I would like to ask the panel to comment on that. What's your experience on EVOH in general? Maybe Sanjeeva?
I think I used this one, EV3 Onyx, mostly in the GA bleeds and some cases of combined with coils for large portostimations. So when I use alone, I do exactly the same technique. Inject very, very slowly. First form the plug around the tip of the catheter and try to fill distally all the way to the site of bleeding site, and then stop it there. Given that this it doesn't stick to the catheter, you can take your own time to go very, very slow. Unlike glue, where you're wounded very quickly, the catheter has to be moved. In this case, you can wait for a quite long time until it fills very well. In cases where you want to combine with the coils, coils could act as a holding agent and then fill the entire coil space to have a better occlusion in cases where you don't want to use many coils.
Osman, yeah.
Yeah, those are all really good points. I mean, I think the things that I would add are, I think EVOH-based liquids are my preferred liquid because of the control that you have, and when you go really slow, which is the way you want to go, you don't have to worry about catheter adherence or anything like that, and then it's also highly radio opaque, so the tantalum makes it very, very easy to see, which again sort of allows for sort of operator control and comfort in using it. And I think also, I think the one downside being the DMSO, again, that really promotes you to inject very slowly, because if you inject that fast, then the patient will have, a pretty extreme pain. So all those things kind of, lean towards, doing a very slow, controlled injection, making sure you get a very good occlusive fill and prevent the recanalization, as Jafar mentioned.
Quick question from Dr. Saad. Everybody knows Wild Saad as a world expert in portal hypertension, but he does more than that. So what's your experience about EVOH in general?
It's just to emphasize what you said, it's just to make sure that it fills circumferentially, that you actually are filling it all totally with inside. So going slow and making sure that you top it off properly.
Great point. Satish, what is in your experience compared to glue? I know that glue is cheaper here, but when do you use this in India over glue?
So here in India, to give you a comparison, a vial of glue will cost you about anywhere between $7 to $10, whereas a vial of EVOH is in the hundreds.
Yeah.
So the advantage of EVOH, as you rightly said, is non-adherence to the catheter. You can take your time, you can keep your heart rate low when you're injecting and all that stuff. But that advantage also comes in with certain amount of volume. If you're going to inject a very small volume, I guess there isn't much in terms of the advantage of EVOH. So most of the time we end up using glue for that. Like, as you said, GI bleeds, or rarely in GI bleeds. Most of the GI bleeds we would tend to use subcoils.
Yeah.
But when we have to use glue, it's a very small volume.
Just, that's a good comment. Just from the floor, I just asked by raise of hand, how many of you use EVOH in your daily practice? Just 3 persons. So it's a good idea to discuss a little bit more, because clearly this is something that is going to grow. And by the way, in the US now, we have also lava from Sirtex. There is also Phil from Terumo. And then there are many other materials coming out. We can discuss about that. Mark, you're up.
So yeah, just I mean, everything that I discussed about EVOH-based agent, be it Squid or Onyx, is very correct. I just like to stress the fact that apparently here you only get 34 Onyx, which is high viscosity. So if you want to feed in an nidus or go distally, for example in prostate, it would be probably not the best agent to use. Squid is available in 12, so I would recommend that more.
We do have Onyx in 80, which is mainly meant for neuro
Right.
sections, but we used to use it for peripheral.
Ah, okay.
We had peripheral with much more
Okay.
viscous.
We need to make sure that we increase the volume for Kratik, because we don't hear him very well.
So I was just mentioning that we do have the Onyx 18 and the 12 here. For the neuro, can you hear me better there?
Okay.
Can you hear me better?
Now maybe you talk with this.
Okay. Can you hear me better now?
No, it's not better. So, so you were saying that Onyx 18 is not available in
No, Onyx 18 is available. Previously, we were using Onyx 18, which is mainly meant for neuro work. But now we have the Onyx 32 or which is more viscous. And we also have another company for mineral using equivalent Onyx called Genox, which is slightly cheaper and it also comes in smaller vials. Satish was mentioning about Onyx comes in the one size. Genox comes in the smaller vial, so only thing is the cost you use. You only use less amount of Onyx. You want to save money.
Okay, so maybe we can change gears here and go to particles.
Mark, before you leave to this, there are a question from the floor, but before that, when you treat for PAE, basically you don't start to make the lava, you want to go distally and then pack up backwards, right?
Exactly. That's
Okay.
what we do.
That's very interesting, because it's a total different way of using it in other areas. So you had a question here, go ahead.
If we take the comparisons of concentration of 30%, 15%, so in Onyx, like it's 34 and 18 are available. So like which case scenario, like if in glue we know that like we need some proximal embolization, include 33% of glue. Like we have to go distal penetration, we know 15%. Like in peripheral setup, if in Onyx or in Squid, we have a 2 concentration. So like where to use which and what are the properties with, or is that just one we can use for every case?
So your question basically was that with glue you can adapt the volume and the speed of how you inject it, but can we do that with Onyx? And you are right, on Onyx there are only a few dilutions, right? You have 34, 18, now with Squid you have 12. I think the only difference is, in my opinion, maybe you guys can comment, is the speed of injection. If you go with 34, it's very highly possible that you can't just do proximal embolization because it's very concentrated and it's going to be really forming the plaque. If you inject that 34 a little bit more forceful, it will go more distally. But it is not something that you can teach because it's very personal experience, in my opinion. Any comment from the panel on that? So your choices are really limited to what you get and then your own experience. But you have to be very careful because sometimes when you force it at the beginning, it may go backward too. So with the 34.
Like one or two examples, like if it is a prostatic artery embolization, okay. So there is so it's a given just Onyx 34 or Onyx 18. Which one to use?
Onyx 18, and actually Sapoval is using Onyx, not Onyx, but equivalent of Onyx 12. So you want less concentration.
Okay, okay. Like Onyx 34 will be used in where and also?
When, for example, if you are very close to the area of bleeding in a vessel and you want to embolize at the tip of your vessel, that's where you can use 34. In peripheral, usually 18, right? How many of you have used 34 for peripheral? Very rare, so usually 18.
So 34 is also good for embolics.
For what?
Embolics.
Endolix.
Because also, well, maybe it's specific to France, but the only when you use Onyx 34, you have these large vials which you don't get with other dilution. So that's one of the issue of using it for embolics, because embolics you need a lot of material.
So before going to the micro, thank you so much for your question. Before going to micro catheter, micro particles, yes, there is another question? Same question? Okay. You want to talk about lipoidal later or now?
We don't have lipoidal now.
Okay.
So I think we can switch to microparticles.
All right, so before that, there are in the US now 2 hydrogel-based materials. One is called the Fluidex GPX, and the other one is Instilla, right? So basically, what you need to know in liquids, you have glue, which is probably the standard of care, where you can adjust the dilution and so how distal it will go. Then you have Onyx, where you can do proximal to distal, but if you really do it the way that is not recommended, you can do distal to proximal, what Mark just did. But then the hydrogel material that is in the US, they are not created for proximal occlusion. They basically are space-occupying material that will go with the flow as distal as possible. So if you want to do vessel sacrifice, or you want to do tumor embolization like angiomyolipomas, or those are ideal because they go distally. What is important, we'll talk about that at Guest New York, was selection of this material based on the level of occlusion you want to have. So if your level of occlusion is between 50 to 100 microns, you use those hydrogel material that just go with the flow. If you want to go between 100 to 300, you can use definitely glue, or you use Onyx in a situation where you inject it a little bit more speedy, but the problem is that it will go from the distal to the tip of your catheter. And then when you go to higher level of occlusion, then Onyx is ideal. So you need to choose your embolic materials for liquid based on the level of occlusion. So you need to know what size vessel you want to occlude to choose that. And there is the last one I would like to mention is Obsidio, or the new category called, they call it something else.
Conformable liquid.
Conformable, yeah. I am actually guilty of that name too, but I forgot about it. So conformable is basically something that is related to the force. You know, you compare it like ketchup. If you look at ketchup, is in general solid, but when you want to get it in, you have to push it so that it comes out suddenly as a kind of solid, and then if you add a liquid. So like the other thing is the two-space, you know. So these are like two-space material, where if you inject it Contrarily to Onyx, you don't have to inject it slowly. The faster you do, the better proximal it will be, because when you put the pressure, the material becomes like a liquid, and then when you remove the pressure, it becomes solid. So that's also, I don't think Obsidian is available in here. And it's very expensive in the US, but the same type of price that Onyx. Any comment on that? Sanjeeva, you have used that, right?
Yes. I think you need a lot of experience to use liquid embolic agents. Most of Indian faculty members would have used glue very well. And glue has a lot more versatility in that you can choose 10% concentration to 80%, 100% concentration as you like it to needs for the case. And most of the time we inject glue very slowly. But when you come to conformal liquid embolic agents, if you inject slowly, it behaves like a gel foam going distally. If you really need to inject extremely fast to make a plug, it's distilled to the catheter. Advantages of all these new embolic materials is it takes away the fear that catheter will stick to the embolic medium. None of the new embolic mediums stick to the catheter. So you have much more longer time to work on it, fix it. The newer one, the polymer-based, both Instilla and GPX embolic materials, they do go extremely distally, and they behave similar to alcohol, as if you're injecting alcohol more distally into the tumoral circulation. So they have some advantage, and they work really well to embolize tumors.
Great. One last thing. I have actually glued a catheter with Onyx. It can happen, but it's very rare. One tips and trick is that when you inject and you think it's going longer, just try to move a little bit the tip of your catheter. But if that happened, there is one way to get it out, is just pull a traction on the catheter and wait. And then pull a little bit more and wait, and pull a little bit more and wait, and then it will come out. Because it is not adhesive, it's cohesive. Anyone has seen that with Onyx? Okay. Well, that shows or age or experience. Sorry, Mark, go ahead.
Usually both, right? All right, thank you for these great comments. I think the market is obviously very different here in the US and in France. For example, in France, we don't have Laval, we don't have Obsidian yet. Anyway, so let's change gears and go to the microparticles. So basically, you know that we have calibrated microparticles, which are basically microspheres, and non-calibrated microparticles. I'm speaking only about permanent embolics. When we say permanent embolics, that means we'll stay for 10 years, we will stay for months, and then recanalize more or less according to different features. So what we use, at least in my practice, the most is calibrated particles, and there are basically two brands. There's American sphere and there's Variant Obosine. We don't have Variant Obosine here today. Maybe it's not available in India. I have no clue about that, but it's not available. Okay. So I don't know if you can show these. Can you zoom on this one? Obosphere.
Yeah, we can see it.
Okay, good. So I'm proud of this figure because it's a French patent done by a good friend, Alex Laurent. He was the king of calibrated particles and the particles like that. So there are different diameters and calibers. For example, what I have in hand is 100 to 300, and then you have 3 to 5, and you have 5 to 7, etc., etc. So what we generally use in our practice for prostate, we use 3 to 5. And for fibers, we use 5 to 7. But it's kind of a very good material, very well recognized, and a lot of publications on that. Wouldn't include the microcatheter if you use proper dilution. So opposite to that, you have non-calibrated PVA-based material, like this one that we have here, like the bearing from also Merit, and there is the contour from Boston, which is also non-calibrated PVA. So there's nothing really to show here in terms of hands-on demonstration. You don't just need to do the proper dilution, inject very slowly, and then get the job done.
Can I, Mark?
Maybe you can discuss now.
Yeah, are you going to show a dilution, or can we discuss about that? All right. So let me ask you the participant. How many have used embospheres? Much more. How many are using PVA in general? Much more people. So PVA is cheaper, right? No, it's not necessarily cheaper.
Well, not by a big margin.
Okay.
It's about 60% of the cost difference.
Okay.
The calibrated are about 60% more expensive.
So the thing that most people don't know about particles is that they think every particles are similar. So if you have 100, 300 microns PVA and you have 100, 300 micron embospheres, one thing is important is to know they are not going to end at the same place. So the reason is that the particles are like PVA, they can clog together, and because they are not compressible, or if you get the calibrated spherical, the compressibility will change significantly to the embosphere. So they end up more proximal. So let's say you want to embolize a prostate that is usually 300 to 500 microns with embospheres. If you want to use the same endpoint with PVA, you have to go to a smaller size PVA because there is no compressibility. So something most people don't know, but it's very important. The other thing is that PVA is already irregular, so you can mix it back and forth, there's no problem. But embospheres, if you do the same thing, you can fracture the particles because they are compressible. So that fracture can end up with some fragment that can go more distally. So how do you prepare embospheres? Just wanted to ask any tips from the group you want to?
So in my practice, I see it as if you're going to look for cell apoptosis, like if you want to have a UFE, fibroid or a prostate, then definitely a calibrated is better for the reasons that you just mentioned, because the penetration is much deeper, and the end results are much better. Of course, it also comes with the other side of necrosis and other issues. But if you choose the right size, and it does squeeze in a bit more. However, if you're looking at stopping bleeding, like a bronchial artery embolization, then definitely we would prefer particles more than a gelatin.
PVA.
A PVA better than a gelatin one, where it doesn't squeeze in and go distally and causes necrosis. So
very good to know.
That's the kind of
Just Val or Osman, how do you prepare embospheres?
Yeah, I mean, for me, it's fairly straightforward. It comes, in America at least, it comes in a little bit of a bigger vial, but usually about 5 cc's of saline with the particles. So typically I take about 10 cc's of contrast, and as you mentioned, with a 3-way, mix them gently back and forth to avoid any shearing or fragmentation, and then create a nice suspension. And basically, you know, I typically deliver it in either 1 or 3 cc syringe.
We don't have variant material here, right? Embosin.
No.
Because one thing important, the dilution is different from each material from each company. So do you have a comment, Sanjeeva, on that?
No, I think I do exactly what Osman said. I only increase the volume. So
yeah.
Instead of mixing 5 ml what it comes with the 10 ml contrast, I actually make the 5 ml to 10 ml and add another 10 ml contrast. The more dilution you make, the better distributed the particle is going to be. Initially, when I tried in India, Matthew used to tell me you should dilute it 40 ml to inject. So.
Exactly, especially if you want to use it for knee embolization, make sure that you dilute it twice. Now, ideally, you need to have 50% dilution. So one thing that's very important, and when you look at the 5 or 6 cc of the solution that we get, 3 cc of that is particle itself. So basically there is only 2 to 3 cc's of saline. So you need to say you have 2 to 3 cc's of saline. If you want to get to 10, you have to add another 2 to 3 cc's of contrast, and then the rest of it is 50% contrast and saline. So some people forget that there is this 3 cc's of particles are not part of the 50% dilution. You have to subtract that. So basically 50% contrast, 50% saline for PVA and embospheres. But if you use material like embosin, the dilution of contrast and saline is based on the size of the material you are using. The other thing that's very important, Mark, we don't hear you. You want to talk?
Yeah, you can finish and I'll give a comment.
Yeah, one very important comment is that when you get the particles from any company, ask how many particles are in that volume. So what is important to know is 100 to 300 microns embospheres usually is equivalent of 200 microns when you come to unique size particles, companies like Terumo or Variant. It doesn't mean that they are the same. Sometimes the difference between one vial of embospheres and one vial of others is probably 100,000 of particles. So if you are used to do embospheres and then somebody comes with a new material and you say, okay, it's 300, 300, I'm going to use the same thing the same way, you may already end up to have a much faster occlusion because there are much more particles in one, and then you say, oh, that doesn't make sense. So these are the things that we don't know because nobody talked about that. So if you, next time you have a rep coming and ask for trying a material, ask them, how many particles do you have in this? 90% of those they don't know. And so I have a table, I know it's not from me, it's from Dr. Keigo Osuga. It's very important to share that with people to know that apples, you can't compare apples and oranges. So be very careful, especially when you go to a smaller size. Particles, the number of particles increase significantly. Some of those are millions of particles. So be careful on that also when you select the particle. All right, Mark, any question?
So, first question, how it's 9 o'clock? Can you tell us how long more we have?
I think it's until 9:30, right?
Okay.
Let me check one more time.
Okay, so let us know. So just a quick comment about particles. Let me focus on PAE. So we used to do prostate artery organization exclusively with Ombudsman 55. The issue is that you have two issues with this material. First of all, you decriminalize and explains fair amount of records, reason why we make the big obliques and actually to value.
Can go till 9:30, 9:45.
Point number one. Point number two, when you get particles, it's very difficult to see exactly what you're doing. Even if you use a lot of contrast, it's much less radio opaque than when you use liquid obliques containing tantalum. So for non-target organization, it's much easier when you use this type of heavily radio opaque material. So it was just a comment. So let's move on to, do you want to move to coils or to drug-eluting particles? Because we have to review also blood, coils, and microcatheter. If we have time, I think microcatheter we can maybe skip.
Let's finish with particles. So drug-eluting quickly if you can.
Yeah, sure. So everybody knows that drug-eluting particles should be loaded with anti-cancer drugs. It's a challenge of the competitor to regular CTAs with the pyranol elution. So we don't have the time to show you today, but we have loaded particles. So two brands here available here, DCBs and a Hemisphere. So maybe Kartik, you can comment on that, on your experience, on what you have available here, and what you use this for.
We use DCB for HCC, taste, and usually use.
Can you increase the volume?
Can you hear me now?
Now it's very good.
Okay. So we use DCBs for taste for HCC, and when we like to do conventional taste, if doable, otherwise sometimes we use DCB taste, we use 300 to 500 particles, and we also have hepaspheres, both are loaded with doxorubicin. Hepaspheres come quite small in size, but when they mix up with the doxorubicin, they swell up 3 to 4 times the size, so we have to be very mindful of what size we choose. So when we choose a 50 micron hepaspheres, usually they swell up quite big, so we use the hepaspheres and the DCBs for metastasis.
So one quick comment on that from my side. I'm not doing a lot of IO myself, but I think the panel can jump in. What I have seen from outside is relative reduction in terms of indication for chemo due to systemic drug therapy in HCC. So for HCC, you have radioembolization, you have drug-eluting particles, you have blood embolization, you have conventional CTAs, and now you have all these medical treatments. So I don't know what's the experience of the panel. I don't know if you have time to comment on that briefly. What's happening in India, for example, do you see a decrease also? Or?
Yeah, in my practice, we move a lot from taste, either we go straight to care, because care is now expanded its role in treatment, even from small diseases all the way from curative intent to palliative intent. So the role of care is expanded and we've shown better results head-to-head with trials. So in my practice, we move a lot away from taste to care. The only place to use taste is, as a financial constraint, taste is much cheaper in India because the care of the research and is coming at a huge cost. So in that situation, we have to do local therapy and the nation is more than 360 years that we go for a taste and that time we go for conventional taste. And so yes, the role of taste, as Mark mentioned, in my practice at least, I don't think we can implement this, but it's diminishing.
So for the sake of time, I mean, we can discuss this for the next 30 minutes or hours, but we have a lot to show. Do you want us to move to coils or what do you want us to do?
Yeah, let's go for the coil, I think. That's something that has been also evolving a lot.
Okay. So what I've seen here when I came is that here you have a lot of brands available. So we want to discuss pushable versus detachable. We want to discuss 018 or the smaller platform versus 035. So apparently what I can see here is that you have the bad pushable, you have the cool pushables and retractable, you have the pod and packing coil by Penumbra, you have the Boston Vortex pushable small coils and large coils. And also interesting for me, there is this company that Kartik was commenting about, which is Merrill, which is the same company doing this Onyx thing, right? No, not Merrill. Okay, another company. Okay, so they have here a large O35 coil. I don't have any experience on that, so maybe you can comment on this very local product.
So the Embo Nest is called, they come in 035 and 018 platforms. They're both pushable coils, fiber coils. They are very similar to the Nesta coils, platinum coated, so they have a good really best.
Can you increase the volume again?
Yeah, sorry.
Good.
Need to keep the mic closer. So the Embo Nest is the coil Mark was mentioning about. It's a company called Merrill which makes them. We have pushable coils from them in 018 and 035 platform.
I like the name.
And these are fiber coils and they are very similar to the Nesta coils with fiber as well. Hence the homogeneity of it. And these are pushable coils and they are good video message, good similar to the Nesta coils.
I love the name actually. Embo Nest is a very nice name. So how many people use that in India? 2 person. How many use other pushables or detachable from, like Penumbra? Penumbra, 1 person. How about the pushable? Majority?
Pushable mostly from
Mostly.
scientific and
Detachable in general? A few shaky hands, so it's probably more expensive. So, and Embo Nest is a pushable, right?
It's a pushable coil, yes.
And it seems that it's really a lot of fibers.
Yes.
Great.
Yeah.
And only on 35, you don't have a micro catheter?
018 as well, so 018 and 035 coils.
0182.
Yeah.
So maybe we have a flow model. I don't know if you can see. We'll try to show you the delivery of a Cook retractor, which is a detachable peripheral mobilization coil. Comes in 018 and 035, and we're going to try to 035. Okay. So
Let's focus on the microcatheter.
so you should focus here. So I'm just pushing the coil out. Can you see something?
Right now we don't see the, yeah, now we see the catheter. Just put the catheter on the center of the image.
Zoom,
Yeah, that's great.
yeah.
So I'm just pushing it basically out of the file. And you see, you can see, so now we're in the right brain lottery, not because it is the best indication, because it was the easiest way to use this model. Apologies about that. So what you can see is the pullback of the parent catheter. You see this movement?
Yeah, the kickback, yeah.
It's very, very interesting to see. That's not real life, but actually it's real life, because then if you end up like that, you're not in a good situation. So you need to retract.
So the kickback is something very important with a lot of coils.
Kickback. Okay, so I'm just
Showing what not to do. Right. Good.
That's the main purpose. This is my current practice stuff. So where are we? In the open.
So in those situations, having a detachable is very helpful.
Yeah. Oh, so it's a situation of a very high flow arteriovenous fistula dural artery. You know. So I'm just going to detach it. So do we have a talker?
So can you focus on where the coils are, because now that should be in the center.
So now I'm pushing this. I'm using this handle to do counterclockwise rotation. And detachment.
That's a mechanical detachment.
Yeah. Can you see the detachment? I don't know what you can see actually.
Right now we just see the tip of the. Now we see your hand. That's very good. So you turn it. Yeah. All right. And then now, can you show us the coil?
Just above the coronaries.
Yeah. All right. We don't see the detachment yet, but I think we should go more fair.
Yes, it's detached. Okay.
Okay. Well, we don't see it. That's okay.
That's right.
We believe you.
So yeah, please believe us. So if you can zoom in on this small box here. So this is the landscape of the pushable Cook 018. The one I would use most in my practice would be this, which is the Tornado. I don't know if you can see it, which has kind of a pyramid shape. I don't know if you can see it in my hands.
Yeah.
And the Nestor, which is this one. You see a lot of fibers. So this is pushable 018. So in our practice, I think if you're concerned about cost, we would certainly go with this to start with. For example, when I did hemorrhoid in the past, I used only this kind of coil. Now I've moved to detachable because this kind of, and we can discuss this further, this kind of liquid coil, which behave very soft, would be very useful because you can use only one per artery, like for example the Benova packing. So that's where we are with coil. We can review other brands. We have the Vortex, which is basically pushable 018, different sizes like diamond, and you can see here, I don't know if you can see my focus here, kind of diamond shape. So these are very effective pushable coils. Any comment or question on that?
Any questions from the audience? It seems to be that's something everybody knows about coils, but what is very important to know is that no matter what coil you use, you need to have a cross-sectional packing. Don't forget that sometimes with the fibers, you can get an early occlusion, but that occlusion is based on thrombus formation, and thrombus in the body is made to be removed. So if you don't have a good packing with a fibered coil, the risk of recanalization is very high. Any comment on that, Sanjeeva?
No, I totally agree with you. I think most of the coils on the periphery, on the X-ray it looks as if you coiled very well, but a central space will be still open, so you need to pack it very well. One technique I use is first I use a bigger coil to frame the periphery of the vessel
Framing
wall,
coil.
and then slightly go smaller sizes to fill the space inside. One question I have for you is, when would you prefer to use a non-fibered coil compared to a fibered coil? What conditions you would use it for?
That's a very good question. I maybe ask the panel want to intervene on that?
For me, I prefer more of a mechanical occlusion if the patient has a coagulopathy. So if they can't form a thrombus, that's something then I want to rely more on the mechanical effect of just physically occluding the vessel. And I think other areas where I prefer a detachable coil, which tends to be the non-fibered coils, is areas of high flow as well. So where I want to really, again, physically pack that vessel to get that mechanical occlusion and also prevent potential migration.
It also depends on if you want something permanent or not. If it's a temporary problem, like a pulmonary AVM, you want something permanent. You don't want to rely on thrombus for embolization, so you actually want non-fibered high packing permanent coils. That's
Very good point.
Sati? What I wanted to say, because we do know that in PAVMs there is a high chance of recanalization over a period of time. So most of the time in PAVMs is where we would do dense packing, unless you can take an Amplatzer plug there. If you can't take an Amplatzer plug, nowadays, even if we do put an Amplatzer plug, we backpack it with some coils.
I would say one thing, mostly for the juniors, is that when you go for a coil, you go for a vessel sacrifice. That's your principle. So, and in those situations, I agree that mechanical occlusion with circumferential packing is what you are going to aim for. Now, one thing is very important is when you are with patients with anticoagulations or patients who are having bleeding problems, a lot of time this is like patients with abdominal muscle bleeding. In those cases, combination of non-fibered and fibered, or combination of what you mentioned, I think you mentioned, or Valo mentioned, combination of coil and liquid. Those are some of the best way to treat. And in my opinion, the future, at least when you have all the material, is going toward utilization of less coils and less liquid, but a combination of one coil and liquid, or two coils and liquid, or plugs. So these are some of the things that we need to think of. Satish?
Sorry.
Yeah, one last comment here from Satish.
This is very India-specific comment. It's probably something you'll find it strange.
We want to learn.
Now, in India, what we don't have the luxury of is using a pusher wire. So all our coils, microcoils, are all actually delivered using the same diagnostic wire, the wire that you used to cannulate the vessel.
I'm guilty of that too.
So there are a couple of issues with this, because if you're using, say, a 0-1 lumen, something like a pro grade, and then you're putting a 0-1-8 coil, there is always a little gap between the catheter and the coil. And if you're just concentrating on the tip where you're deploying the coil, if it's an ester, it's a 14 centimeters, and if you're not looking at the distal end where you're actually pushing, the wire can go in between the coil and the catheter. And then you will find that you're pushing the wire, but then the coil is not moving. And then when you pull the wire back, the whole coil comes back along with the wire. So that's something to be mindful of. And the second thing is, so in my practice, what I almost always invariably do now is inject the coil to the tip, and then the final bit deploy with the wire. That's point one. And the second thing is, also we have to remember that the diagnostic wire is much more supple when compared to the material of the coil. So just because you have a catheter which has gone through multiple tortuosities, and then you try and push a coil, the coil may not take all those tortuosities. And then you have back kicking of the coil, and due to financial constraints, most of the time we use a pushable coil. And the worst thing is half the coil has not been deployed. And your catheter is not kicked back, and you don't.
This is actually one of the most important teaching points. And when I moved from university to my private practice, where I had to be cost conscious, we ran to a few cases like this. So what I did is that as much as possible when I use coil, I go to 2.4 system, where the coil compatibility with the lumen is much better. Or as he said, it takes some experience, but to know how to inject the coils to get to the tip and then start to push it. But that's really the most important message you can take out of it. So thank you so much, Satish, for that. Mark, go ahead with the plugs.
So let me show you. So plug is a clear competitor to coils and sometimes to liquid bodies when you want to go for vessel sacrifice. Basically, that's the overall, I would say, general consideration. So many different devices in the US, people are getting crazy with plugs. You have at least 10 companies doing plugs. So here we also have companies doing plugs which are manufactured in India. I will show them, and actually Kartik will show them because I don't have experience. But let me start with this, which is the first version of the perfect plug, which is Amplatzer by Abbott. Can you see this one?
Amplatzer 2, right?
Yeah, this is Amplatzer 2. So you see these three
cells.
Different cells, and you can put it back into the delivery catheter that I'm trying to do here. You would push it out. It would open. You need to do oversizing basically.
Do you push or unshape it?
That's a great question. Yeah. So Mark, Sanjeeva made a great comment, and that's very important. First of all, how many people use AVP in India? A few, that's good. So he's asking, do you push or do you pull back when unsheath? So that's a very important.
We unsheath like that.
Yeah. But you can push, it depends on situation. So I think it's...
What you can do is do a combination.
Yeah, exactly.
Short, because for example here it's fully open, so it's short. But if you're in a vessel, which would be this size, it would elevate, right? And then
So if, yeah.
So you can do this kind of movement to push it and shorten the landing zone.
And if you are against the wall, if you put your hand, your finger at the tip while you release, everything will come packing together. And so it can be very small occlusion in terms of cross-sectional, but very packed occlusion. If you pull back and stretch it, you can be unpacked, but it could be very long occlusion. So it depends on the size of your landing zone, that what material you use and how you use it.
So what about the Indian product? You have narrow and you have this container, right?
Yeah.
So if you can zoom in here.
So we have a product from Benny called Plug It. So it's actually the single disc configuration, just like the AVP.
Plug it.
Nice
It
names.
also has
Nice.
to increase the proper density of
Can you see this white thing inside?
Yeah. So it looks like a non-Platzer 4 with a covering inside. A very smart design.
Is it PTFE inside?
24, single disc one. And then have another company as well, which has a company called Lifetech, which has a plug called Sarah.
This one.
Again, it comes in a similar to AVP1 configuration, like a single disc.
Can you see it?
Yes, that's a single disc with covering, right? What is the covering material? Do you know? Is PTFE or PTFE? Yeah.
So three layers of
microcatheter
PTFE
compatible?
in one cage, right?
That's amazing.
But by small wire, you need to know the type of thing, right?
What size microcatheter for this?
These are 035, so it has to
035, okay. That's brilliant.
So 8 French sheet they need.
That says 18.
Yeah. Minimum ID is 8 French.
No, it's 18 diameter.
So it wouldn't go into a microcatheter. So interestingly, sometimes you would like to have a plug going into a microcatheter. Not many of them. The only one I know what we're using is MVPs from Medtronic. I don't know if there are other brands here in India. Okay, so it's very good to have a micro plug going into a microcatheter when you want to do occlusion in a very distal and tortuous anatomy. So open for comment on plugs now before we move to the microcatheter for the next whatever minutes we have.
Yeah, we will, they told us we have more time, but I think just to respect the next session, we will end up at 9:30. So just a question. I have been saying that for the last 20 years of guests, I go to a case and start thinking, is it a case for plug? And the reason is that one, if you can do it, one done and you are out of the case compared to coils. But the problem is that, as you say, not all the plug can go to the microcatheter, and you don't, and you have to adjust the size of your sheaths and everything to the plug you want to use. So here, how many people actually think of plug as the first embolization in their practice? One? Micro?
Or Parto.
For Parto. Great. Actually, Val, what do you think about Parto in general? Because I know you are old school, but...
Poking the bear.
Any comment on that?
No, we use plugs.
You use plug?
Plugs, but
Okay.
coaxially through a balloon occlusion.
Oh yeah, coaxial. Yeah, absolutely. We do the same thing. Plug in. So any other comments about plug? It's just, I think that if you go to a case and see, you know that is a bleeding, or let's say a vessel sacrifice, visceral aneurysm, I always plan, especially for the last course, so post-aneurysm usually is difficult. You have to go with microcatheter and use maybe coils. But before the aneurysm, front door, I usually use a plug, which means that you have to prepare for it for a 6 French sheath or everything, so that it reduces the cost of the procedure, even though plugs seem to be expensive, but like an AVP in the US is $800, while a coil detachable sometimes can be $2,000. So I think it's important to be sensitive about that. Satish?
Yeah, just a practical point again. So many of these plugs with, say, an 8 French sheath or a 9 French sheath on it, but we are using a different company. Many of us will use some Indian-made sheaths and stuff. So you will find that sometimes they are not compatible. Even though it says an 8 French, you probably would actually in reality need a 9 French. So the way we do in our practice is actually look at the ID and the OD, and that will come in millimeters, and that usually matches, because if it says 0.89 or something like that on your Amplatzer recommendation, then make sure your sheath says at least 0.90. And if you take two different companies who all make the same 8 French sheath, one will say 0.87 and the other would say 0.89. And those 2 millimeters will matter. And especially if you're pushing it and then you want to unsheath it back again, it can be quite stressful.
Very good. Mark, I think, just as I said, we maybe have to finish in 5 minutes because the other session is coming up. So let's go on the microcatheter quickly.
So microcatheters and micro wires. Size of the microcatheter, size of the inner lumen, wire that goes in it. As I heard, there are more microcatheters here coming with the wire in the same package, basically for cost containment, cost constraint. So, for example, this is the one that we use basically as most often, which is the ProRave. Comes with this, I don't know what you can see on the screen here. With the stereo-based platform wire, which has a very good torque, as you can see. Potentially, you cannot see anything. Anyway, it's not film, it's liquid. So we have all these brands. Some are pre-shaped, some are not pre-shaped. I think what I would like to comment personally is the use of the appropriate wires and how you can use the wire to achieve where you want to go. And just to show you for the sake of demonstration, what we are using frequently is the OCC Fathom, if I can pull it out. I just want to show you a very quick, if I can pull it out here, how we can shape this wire, which I think is very useful. So can you see the tip of the wire that we put on the white? Yeah, can you see this?
Yes.
Okay, so the way we do it, you have two options to shape this wire. This is the way we do it in day-to-day life and practice, okay? You can do it like that. We will shape it, now I'm going to show you. Or you can do it like that when you want to have a very short TG wire. Can you see that?
Yeah, the best way to cut it too. No, I'm joking. It's really a nice way.
Well, you're right, you can take your hands. So the other way to do it is for a different shape. It's doing like that, and I think it's very useful. And if you learn something this morning, I think it's one of the things that you can shape it like that, and with that you can achieve more or less every curve you want. You can even do a combination, trying to make some kind of a cobra type shape.
Nice. That's a very nice way of doing it. Actually, you know, sometimes I use hemostat, especially in the type of the, some wires are much more resistant. So I just take the tip and then rotate around the hemostat few times. And so one thing that's very important, you need to know the type of wire you use. Some of them, their shapeable part is just distal 1 centimeter. If you go a little bit further, you damage the wire and you don't know. It's just important to know that each wires are not the same. So know the brand you are using and how they are made. I think the more you know about that, the better it is.
So I said table, the whole brand of Asahi is offering to reach on the table. You can see the Meister and the Velut. Velut, I think, is very good to do powerful GA organization with pre-shape. I don't have a lot of pre-shape microcatheter today to show you, but you know that this can be shaped as swan shape
That's great. So we just need to wrap up. So one thing that is very important with the microcatheters is to know the lumen, especially when you use it for coils. It's extremely important to know the inner lumen. Satish, you mentioned that. I think it's very important. The compatibility of the coils and the microcatheters. The same thing with particles. So in general, what I have done now over multiple years, the modification in my practice, especially when I started the OBL, is that I go to 2.4 for everything, and sometimes 1 in 100 cases or 2 in 100 cases, I need to go to a smaller for prostate. And then for the knee, I go directly with 1.7 because even though I know you can do it with 2.4 or 2.1, but I feel that for the knee embolization, you have to go very distal and then come back and proximally so embolize the whole thing. For that, I will use 1.7 microcatheter. Any burning comments on microcatheter from the panel? Satish?
Sorry, one point that we've not touched upon is also the length of the microcatheter. Now, we generally go for a 135, but more and more we are doing transradial for, like, for example, you're doing a PAE transradial. You need to be mindful that 135 is not going to reach. You may need a 150, so that's something to be mindful about.
Very good. So just a few comments. One is that we have an interactive case session at lunch. As guest meets ISVIR, but it's mostly interactive discussion with the panel and with the participant. Second is that we would like to invite all of you to guest New York. There are fellowship package available for younger IR. Guest New York, May 14 to 17. And I would like to thank the panel. Some of them, they had to wake up in the middle of night to come here, so thank you so much. And Mark and Kratik, you guys have done amazing. I can't imagine the amount of work you have done to put this together. So thank you so much. Any last comments from Kratik and Mark?
No, thanks for the opportunity to do this demonstration. I think you have a lot of material and it's very interesting to see Indian company doing very, very smart devices as well.
Nice name too. Kratik, any last comment?
Here to set up things and came really early this morning. Very thankful to the guest team for organizing this workshop. Thank you.
Thank you. Thank you, everybody.